everyone, this is a little tutorial as promised to orient you to the composite filling procedure and give you a better understanding of it so that you can be more helpful when you're assisting at the clinic. So composite fillings are the filling, of course, that we do most often. They replace what we used to call amalgam. Amalgam was an amalgamation of a variety of metals mixed with mercury to create a moldable substance that would harden. And those are actually still well thought of in the profession, but they're unsightly and they're not as beneficial for the teeth. But composite fillings have come a long way since I began my career in dentistry. They are a composite, as the name suggests, of a variety of filling materials mixed with an adhesive. And those variety of materials, the silicone, I don't remember everything that they're composed of, but they're meant to have a variety of characteristics such as polishability, durability, ability to withstand the compression forces of mastication, the temperature variations in the mouth, the constant attack by acids, and the fact that the mouth is always wet. And it ought to look nice and be polishable. So the materials have come a long way over the years, and what we have now is a wonderful benefit for our patients if it's done right. This is very technique sensitive, and that's why it's really important that you become familiar with it so that you can be helpful and understand what we're trying to achieve. So we've got a quick overview of the procedure. I'll let you pause it and read this on your own time. This is the basic armamentarium. It depends on what type of filling we're going to be doing. There are different classifications, but the basics are seen here in this armamentarium. And I'm going to go through it piece by piece. So, of course, you've got the mouth mirror and the explorer, pretty basic. I like to put those on the doctor's side, along with a couple 2x2s and a couple pieces of cotton roll. And that gives the doctor pretty much a great start to the procedure. This is a perio probe, and I don't know why we put it in our kit, but we do. It's in the cassette, and there are certain instruments that I know pretty much guarantee I'm not going to be using during the procedure. So I'll take those and I'll set them aside. It's just less visual clutter, and that enables me to see what I need to see and deliver it to the doctor quickly. Okay, you've seated your patient, you've placed the patient napkin around their neck, you've taken a spray of hand sanitizer and you've worked that into your hands in front of the patient, and the doctor has walked in. The x-rays are up on the computer screen, and you're clear on which teeth will be worked on today. The first thing that you're going to hand the doctor is, after they take their own mouth mirror and explorer, is the topical anesthetic, and that will be placed on. It's nice if it stays in place for 3 minutes. It gives the maximum benefit to the patient. Then you're going to discreetly hand the doctor the syringe that you will have loaded with local anesthetic. So typically, I'd say the most of the time we're using lidocaine, but on occasion, especially on the mandibular, we will use articaine. Darlene and I will help you to recognize the difference. So you discreetly hand that to the dentist, and they will anesthetize the patient. At that point, you will place the lid to the cap to the needle on the tray behind the dentist, and the dentist will use the one-handed scoop technique to replace the cap. You will reach for your triplex syringe and the saliva ejector, and you're going to give the patient a nice rinse. Make sure your PPE is in place, especially that your eyes are protected. You don't want this splashing back into your eyes. Once the patient is numb, the dentist will begin the task of removing the decay using the high-speed handpiece. At this point, you'll be holding your high volume suction, and you'll be holding the tapered edge of it in such a way that you keep the doctor's field of vision open, but you're collecting the debris as well as the aerosol that's being produced by the high RPMs. Now, some doctors will ask, after they've removed the majority of the decay with the high-speed handpiece, some will then go to the low-speed handpiece, the latch type, and remove additional decayed material with that. Other dentists will use this. This is called the spoon excavator, and they will use this to make sure that there's no decay left in the tooth. I put this slide in here just to give you an idea of the different types of fillings that we do. They're classified by the surfaces that are represented, the surfaces that we're going to work on. So a class 1 is just a single surface cavity, and we do not need a matrix band for that. It's relatively, hopefully it's not too deep, but it's relatively simple in that you're just going to fill up the cavity. A class 2, however, is the decay has gone through the axial wall and or the external wall of the enamel interproximally, and so there is a need to place a matrix band there to hold the composite filling material in place, as well as provide a contact between the teeth. So class 2 preps we would need to have a matrix band. Class 3 are interproximals, usually in the anteriors, and these we would need, the matrix band we use for these is a clear plastic matrix band, and a class 5 is usually on the gingival, right at the gingival third, and that we typically don't need a matrix band for that. However, a doctor may use retraction cord to make sure that they have accessed all of the decay and they can see everything and make sure that they have it well in hand. So if we have a class 2, we will provide the doctor with a matrix system. This is one matrix system. That's a matrix band on a Toffelmayer holder, and they will place that to restore the wall of the tooth, and they will use a wedge to make sure that none of the material splooshes out of the bottom. Next, we will hand the dentist, once they're ready and the matrix band is in place, generally the next thing we hand them is the etchant. This is at least 20% phosphoric acid. Again, another great reason to wear your PPE. The doctor will place it on the tooth, and what they're trying to do is the dentin has what they call dentinal tubules, basically pores. But when the cavity is prepped, the static electricity in the air basically will, the tooth will draw a cover to itself. It's called what's it called? It's called, I can't remember the name of it, some kind of a film. So the acid etchant goes into the preparation to remove that film that's on the tooth surface. And what this is going to do, it's going to allow the bonding agent to seep down and create little fingerlets into the tooth to really enhance its bonding abilities. Now, when you hand this to the dentist, two things. You're going to have to move kind of fast. You're going to want to open your bond at this point. The bond is very volatile, meaning it evaporates quickly. So you don't want it to evaporate and get gummy. We want it to have a real nice wetting ability. And so so you'll hand the doctor the etchant, you'll open the bond, and then you're going to grab your high volume suction, and you're just like a catcher's mitt, as if you're playing, ball. You're just going to place your high volume suction in such a way that the dentist can kind of push and rinse all that etch off. Then they're going to rinse. They're going to dry to a frosty consistency, and then they're going to place bond. Now, there's various ways that various manufacturers of bond. This is a universal that we used to use at the clinic. You would just dispense 1 drop of that, place it on the applicator here, the cotton-tipped applicator. And actually it's called the microbrush. You place it on the microbrush, and then you dip the microbrush into the dampen dish there, right? And hand it to the dentist. At that point, the dentist will probably blow a little air to make sure that there's no pooling of the bond, and you will hand the dentist the curing light. So what comes next? Well, it depends on the dentist, and it depends on the cavity. But the next thing that we would likely hand the dentist is the flowable composite. Next, we'll hand the dentist the low viscosity flowable composite. These tips are interchangeable, and it is good to change them, place a new tip on before using it. The doctor will place this into the cavity preparation. Then they would want their explorer, whether they get it themselves or you're holding it. It's up to you and the doctor. They will use that explorer to kind of push the material where they want it to make sure it's not pooling in any place they don't want it, and that it has reached all the corners and little out-of-the-way nooks that they want to have covered. Then they will want the curing light. At that point, you will hand them the high viscosity or the condensable composite material. So this will be expressed into the patient's cavity, and when you do hand that to the doctor, the next thing you're going to want in your hand is the condenser. Take a look at the tips of that condenser. It's just basically a straight up and down kind of just a circular instrument at the very tip of it, and the doctor will condense the material down into the cavity prep. The doctor might also prefer to have a ball burnisher, or they will go straight to the plastic instrument. The plastic instrument is here, the one I showed with the arrow. I want you to get familiar with these instruments because, you know, in the thick of it, when you're in a hurry, they all kind of look the same. So be familiar with the names. So the red arrow is pointing to the plastic instrument. You're going to give the doctor the plastic instrument, and you're going to be holding the 2x2 gauze, and that will allow the doctor, when they have excess, not if, but when they have excess, you will scoop that up with your gauze and allow them to keep working. Remember, they're looking through what we call loops. And so their vision, the tooth is magnified in their eyesight, and everything else is very hard to focus on. So they're going to want to hold out their hand, and they're going to want to know that you can place in their hand what they're going to need next. There's kind of a dance that goes on between the doctor and the assistant. Once you get to know your doctor, or once you know the procedure quite well, you will be, without words, you'll just be handing the dentist the instruments, and they'll be receiving them and using them and handing them back. It's kind of a satisfying and pleasant thing to be part of when it goes really well. If you've used a matrix band, then we're going to use this cotton forceps to remove the matrix band from the Tafelmeier. And then sometimes those matrix bands get pretty tight. They're wedged in there tightly. In those events, you're going to want to give the doctor this hemostat. It doesn't happen very often, but when it does, you're grateful for the hemostat. At that point, the doctor is going to start to shape, polish, and finalize the filling. When they've done that sufficiently, they're going to ask you for This is articulating paper. And of course, while the doctor's shaping, they're shaping with a high-speed suction. They're shaping with a high-speed handpiece, so you're going to be using your high-speed suction, right? Anyway, so then you're going to use this articulating paper holder. You're going to hand it to the doctor, or if when you're experienced, you just place it where it belongs, and the patient will close down, and it will make markings on the teeth, which tell the doctor if the patient is biting first on any given spot that's associated with the filling, and so they can kind of polish that down so that the patient is comfortable. It's just funny, just a millimeter, just one tiny little fraction of a centimeter can be felt in the mouth. I'm sure you've all gotten popcorn holes stuck in your teeth, and you know how that feels. Well, if we leave a filling high, if a person is biting high on the filling that we just placed, that will really irritate them, and all their periodontal ligaments, the millions of PDLs, periodontal ligaments, that are holding that tooth into the bone become highly sensitive. And so that's why the doctor spends a lot of time making sure that the occlusion is correct. Again, if we've used a matrix band, then the doctor will always floss the interproximals.